Good afternoon, everyone, and welcome to the Navigating Menopause Empowering Women Through Change webinar brought to you by Excellus BlueCross BlueShield. I want to start out by thanking each of you for taking the time out of your day to join us here today for our monthly Excel Your Well webinar. As many of you may be aware, October is National Breast Cancer Awareness Month. So with the heightened awareness around women's health in this general time of month, we thought it was the perfect time to focus in on a hot topic, no pun intended there, of menopause. So it was the perfect opportunity to leverage one of our own health plan experts to discuss the topic. And we are excited to have so many of you here joining us here today to learn more. Now, if you are new to our Wellbeing webinar series, my name is Katie Keller-Burgess, and I am part of the Wellbeing team here at Excellus BlueCross BlueShield. So I will be the host for today's webinar, teeing up our guest speaker, Dr. Kathleen Robichon. So today, she will be pulling back the curtain on a topic that's often whispered about, but based on simply the turnout here today, truly deserves center stage to be talked about, which is menopause. Now, this transition is a natural part of life, yet it can feel anything but simple. And that's why we are here, right? To unmask the myths, share the facts, and empower women through this transition with knowledge and support. So we want to start off with a few housekeeping items. Please note that today's webinar and all of our 2025 Wellbeing webinars are being recorded and are being housed on our Excellus BlueCross BlueShield YouTube page. So if you need to go back and listen to this webinar or maybe access a previous webinar on a topic of heart health or mental health, etc., once again, you're able to access those on-demand webinars right on our YouTube page. My colleague Kate is going to put in the chat the link directly to that YouTube page if interested in accessing. And once again, this will be uploaded typically within a week or two following this live webinar. Another housekeeping item that I want to call out is that all participants' microphones and cameras are automatically disabled. Now, there will be time for questions at the end of today's webinar with Dr. Robichon. So we do encourage all participants that if you have any questions at any point, to utilize the Q&A feature within the Teams webinar to ask your questions. And once again, at the end, we will get to questions with Dr. Robichon. And the last housekeeping item that we do want to call out is that it is important to note that the content covered here today is meant to be educational in purpose. But if you do, of course, have any individual health-related questions or concerns, we, of course, recommend that you connect with your primary care provider or OBGYN. Or if you have any benefit-specific related question or concern, please contact the customer care number on the back of your health insurance card. So with that being said, I have the distinct pleasure of introducing our guest forum here today, our speaker, Dr. Kathleen Robichon. Now, Dr. Robichon is the Vice President of Medical Affairs for Clinical Services here at the Health Plan. In her role, she provides strategic clinical leadership across key areas, including utilization management, medical director team operations, as well as quality programs. Dr. Robichon has been instrumental in advancing the health plan's initiatives in cardiology as well as maternal health, driving innovation as well as improved outcomes for our members. Now, prior to joining the health plan in 2019, Dr. Robichon practiced as an OBGYN physician in Rochester for over 2 decades. Her deep commitment to women's health continues to shape her work, particularly around the area of menopause education. So she has delivered numerous lectures empowering women with knowledge and fostering open conversations around this topic. Dr. Robichon is known for her passion, clinical insight, and dedication to improving care through her education as well as advocacy. And she was more than happy to step in here today and support the webinar on this topic of menopause, and we are so grateful for that. So with that being said, Dr. Robichon, once again, thank you for being here today. I will turn the stage over to you.
All right. Thank you, Katie. I am very excited to be able to speak with all of you on a topic that affects so many, if not all of us, at some point in our lives, menopause. It looks like from the number of people we have here, this is a really important topic, not just to me, but to all of you. I'm going to touch on some facts about menopause, a little bit about the stages of menopause, try to help you understand what's happening hormonally and throughout your body, what the symptoms are, how we can manage and treat menopause, how we can encourage you to partner with your provider, and give you some resources to support one another throughout this process. And thank you again for attending. I'm super excited. So, what is menopause? Well, the definition of menopause is basically 12 continuous months without a menstrual period. And in my clinical life, I had the dubious distinction of having patients come in who are like, Dr. Robichon, I haven't had a period in 11 months, but now I got one. And then I have to tell them, okay, I'm sorry, but the clock starts over again. We got to keep counting again from, ground zero. So it is a crazy time, an interesting time, and we're going to try to make some sense of it. About the age of natural menopause in the United States is about 51. A lot depends on ethnicity, and we'll talk about that briefly in the future. About 50 million women in the United States are currently someplace in this menopause transition. So there's a lot of us. The average duration of the menopause continuum is about 8 to 10 years. It can be shorter, but it can also be longer. And also, a little more than 5% of the US population has early menopause for reasons that we don't clearly understand at this point. I think the only thing that I can say with 100% certainty is that menopause is wildly unpredictable. Some women have dramatic changes in their periods. They get very heavy, more frequent. They can also go in the other direction where you start skipping periods, they become lighter, symptoms run the gamut. It's generally a very confusing time that catches all of us by surprise. So no, it's not just you. Typically, menopause symptoms start in the mid-40s. There's early menopause, which is really that time when your periods might still be pretty regular. You're probably still ovulating. And you want to make sure that if you're sexually active, that you are using contraception. Otherwise, you can have an oops baby late in life that you might not be prepared for. The late menopause transition is really when you start to have an increase in symptoms. Your periods may start to skip, a lot of irregularity to that. Again, menopause is that 12-month time that you go without a period. Then there's early postmenopause. That is when the first 4 years after you stop having a period, and then late postmenopause is from 4 years ad infinitum. So a long time. Menopause is associated with marked decrease in ovarian estrogen and progesterone production, as well as testosterone to some extent. Typically, what's happening in a normal cycle is there are hormones from the pituitary gland that stimulate the ovary to create an oocyte or egg. The idea is that that egg then starts producing estrogen and progesterone. The levels go up. It stimulates the lining of the uterus to prepare for an implanting fertilized embryo. As we get to menopause with the irregularities and then postmenopause where you stop having periods, the ovaries are not producing as much, are not producing estrogen and progesterone as much. There is no oocyte, ovulation is not happening. And then we start to see some of the side effects that come with menopause. It's important to know that estrogen does many good things in our bodies when we are premenopausal. It is actually protective to cardiovascular tissue. It helps maintain blood pressure. It actually works to keep our lipid levels in a healthy range. Estrogen works in our brains to promote blood flow. It actually assists in memory and fine motor skills. We know that estrogen works on our muscles to create lean muscle mass, as well as our bones to improve bone density and protect against osteoporosis. Estrogen also works in the brain to stimulate serotonin or to keep serotonin levels regular, which helps to create good mood. And we also know that estrogen plays a role in vaginal tissue to improve the lubrication and improve sexual intercourse. And progesterone's role really is mainly in related to ovulation and implantation of that embryo, hoping to carry a pregnancy. But it also does work in improving mood. It works with thyroid function. And then in women, after they've had a baby, it plays a role in lactation. So lots of things that it does all around our bodies. Now, we know that menopause can affect almost every aspect of a woman's body from head to toe. About 75% of women will have vasomotor symptoms, typically hot flashes, night sweats, related to changes in estradiol levels. About 50% of women will have some sort of vulvovaginal atrophy, vaginal dryness, pain with intercourse. So those are the big ones that we think about. This slide kind of shows every aspect of your body that's affected by menopause. Um, the symptoms are very diverse and they don't always get appropriate attention. All of us have a very different menopausal experience. There are so many potential symptoms. And, you know, like I said, we know about hot flashes, we know about irregular periods, vaginal dryness, night sweats, weight gain. But one of the things that it's starting to get a little more study is estrogen has an anti-inflammatory effect throughout our body. And this anti-inflammatory effect also is seen in our connective tissues. It helps to promote elasticity and strength. So when estrogen levels drop with perimenopause and menopause, we will sometimes see that in our joints. Um, we see it as an exacerbation of tendinitis very often. Typically, it's in the joints that tend to get used a lot, our wrists, our elbows, our shoulders, our hips, our knees. And menopausal women are developing something called gluteal tendinopathy. It is a very deep hip pain that is very uncomfortable and is often misdiagnosed as osteoarthritis. So people try to take non-steroidal anti-inflammatories. It's not going to get better. They go to their doctor and get x-rays. They don't see anything wrong structurally with the hip. It's not until we start diving a little deeper that we start to see that things are changing a little bit. And it takes us to that path of what are we going to do? And gluteal tendinopathy can get better with physical therapy and sometimes with estrogen replacement therapy. So that's something to think about as we go through this process. I apologize for the difficulty in reading this slide. This slide looks at several different ethnic groups, the average age of menopause for those groups, the most severe and frequent symptoms that they have. And while many of the symptoms are similar, it goes back to the fact that we all experience menopause differently. And Black women tend to enter perimenopause at earlier ages than their white peers. They tend to have longer menopause transition. They experience more intense hot flashes and vaginal symptoms. In a study called the SWAN study that was done several years ago, they found that the typical duration of hot flashes and night sweats was about 6.5 years in non-Hispanic white women, about 8.9 years in Hispanic women, and over 10 years in Black women. And the reason that this is important is many of these women that are going through these symptoms early do not seek treatment for it. And that tends to put them at greater risk for diseases later on in life, like cardiovascular disease, osteoporosis, dementia. So this is my motto, and I'm going to repeat this maybe one or two more times. women should not suffer in silence. So if you are having symptoms in perimenopause, menopause that are affecting your quality of life, you need to make sure that you are speaking to a healthcare provider about that. Remember how I told you in an earlier slide about the hormonal changes with menopause kind of starting in the ovary, which is true. But many of the symptoms of menopause are things that we feel throughout our bodies, and they kind of start in our brains. Honestly, the hot flashes and night sweats, these are changes in body temperature that are regulated by our brain. Anxiety, depression, insomnia, all related to things happening in the brain. Brain fog, memory lapses, again, things that start in the brain. And we know that premenopausal levels of estrogen and progesterone actually protect our brain. There are estrogen-related proteins in the brain that are located in regions that involve learning and memory, such as the prefrontal cortex, the hippocampus, and the amygdala. We also know that estrogen regulates brain energy levels, supports immunity, and promotes cellular growth and communication. So during perimenopause and postmenopause, lower estrogen levels start to affect the brain, and we see that as brain fog. We start having memory issues. We may have some more emotional lability, sleep disturbances. So things are happening all over. It's important to pay attention to what's happening in your body and making sure you're addressing it with your healthcare provider. Now, as I mentioned before, estrogen has anti-inflammatory properties. As well, it helps with vasodilation. It also contributes to a favorable lipid profile, meaning those HDL or good cholesterol levels are higher, and those LDL or bad cholesterol levels are lower. All of this works to be very cardioprotective for women. But women become at increased risk for cardiovascular disease after menopause. What's happening is they're producing less estrogen. That protection on their lipids and blood vessels starts to wane. The arteries become more vulnerable to disease. They get thicker and stiffer. Women also start to gain weight, and typically they gain it in their midsection, so they have more belly fat. They also developed increased visceral fat. What that is it's fat around our internal organs. All of this increases our risk for cardiovascular disease as well as insulin resistance, which can develop into diabetes. And studies have shown that the cardiovascular disease risk factors for women start to approach those of men about 10 years post-menopause, so typically around the age of 60. And we want to make sure that we are appropriately identifying people who have cardiovascular risk factors when we decide what sort of treatments we're going to do for them. And that's where this slide comes in. It's basically an atherosclerotic cardiovascular disease risk assessment tool. I understand that's a mouthful. Don't expect you to remember that. I just want you to think about the things that go into this, because this is how we develop an individualized plan for how we're going to manage menopause for women. So we look at past medical history. Do you have high blood pressure? Do you have diabetes? Are your lipids abnormal? Do you have an autoimmune disorder? We look at pregnancy history. Did you have gestational hypertension or gestational diabetes? Did you have preeclampsia? You know, all these things go into it. Family history. Do you have a family history of cardiovascular disease? What is your social history? Are you a smoker? Do you drink alcohol regularly? And what is your lifestyle like? Are you active or sedentary? We can also look at biomarkers in labs. So look at blood pressure, BMI, weight, waist measurement, which is a big factor for this, lipids, fasting blood sugar. And that gives us an idea of, okay, here's your score. How do I want to use that? And I'm going to bring it back in a future slide to show you what this means. But it's important in establishing what we're going to do for managing people with their symptoms of menopause. So here we go. Treatment options. Menopausal hormone therapy is basically the broad term we use to describe giving estrogen and progesterone to perimenopausal and menopausal women, the goal of menopausal hormone therapy is really to alleviate hot flashes. It's a systemic therapy. Hot flashes are a systemic reaction. And in fact, the FDA has only approved menopausal hormone therapy for the treatment of vasomotor symptoms. We do use it off-label for some other indications, but that's the only FDA-approved indication. Estrogen comes from many different sources. It can be bioidentical. The one that's most commonly used in traditional menopausal hormone therapy is called conjugated equine estrogen. That is derived from the urine of pregnant horses. And we also have other synthetic or compounded estrogens. And again, the idea behind this is let's treat what's going on for the individual. If it's systemic hot flashes and they're low risk, maybe menopausal hormone therapy is the best thing. But if your only problem is maybe you have some vaginal dryness or difficulty with intercourse, maybe we treat you with something that's specifically for that, an over-the-counter vaginal lubricant or something along those lines, so that we're treating what's bothering you without putting you at risk for other things. And an important thing to bring back now, I mean, estrogen comes in all different forms, pills, patches, implants, creams, gels, rings, suppositories. The most important thing is we want to make sure that we start hormone replacement therapy within 10 years of the last menstrual period or before the age of 60, because that's when we start to get concerned about the increased risk for cardiovascular disease for women. Another thing that comes up from a risk standpoint is risk for breast cancer related to hormone replacement therapy. And what I keep in mind is that for women who are on estrogen and progesterone, and we give progesterone to women who have an intact uterus to protect their uterus, typically about 7 years of hormone replacement therapy is around the time we would want to think about stopping, because that might be when risk starts to increase. I'm sorry, that's for estrogen alone. For combination estrogen and progesterone, it's typically in the 3 to 5 year range that we would want to talk about weaning off or stopping, because we want to make sure that we're not putting anyone at risk for another disease while we're treating symptoms. Testosterone. We do use testosterone for women who have low libido or sexual dysfunction that have not responded to other therapies. Again, this is an off-label use, and you have to watch this because of the side effects of testosterone, which can be acne, there can be some unwanted hair growth, and even some changes in your voice. So things to keep in mind. This is what I talked about related to the ASCVD. This is the shared decision model to help develop a personalized treatment plan for menopausal hormone therapy. The first thing I do is I look at risk factors. So if you've had recent menopause, you're relatively normal weight or normal blood pressure, you're physically active, your 10-year ASCVD is less than 5, and you're low risk for breast cancer based on family history and whatnot, and you're having significant symptoms that are disrupting the quality of your life, I might recommend menopausal hormone replacement therapy. If you have coronary artery disease, you've had a blood clot or a pulmonary embolus, you've had a stroke or a heart attack, or your ASCVD is greater than 10, I'm going to try to find something else, because I would not want you to be taking estrogen therapy. That would potentially increase your risk for unwanted side effects. This intermediate risk is probably where we struggle the most, and that's part of where we individualize a plan, understanding individual risk factors, what someone is comfortable with, and what I, as a provider, am comfortable with as well, and try to make an informed decision. In anyone who I put on hormone replacement therapy, I am seeing them regularly to make sure nothing's changing in their medical history, that their symptoms aren't changing, that they're getting relief. And again, the idea is we want the lowest dose of hormones for the shortest amount of time to make sure that we're treating the symptoms that are happening. Now, there are some people that don't want to take traditional hormone replacement therapy, and we have bioidentical hormones. These are hormones that are derived from animals and plants, but they're chemically identical to what happens in the human body. Again, estrogen, progesterone, and testosterone can be bioidentical. They come in many different forms, also pills, patches, creams, gels. The FDA has actually approved some bioidentical hormones. The estrogens go by estrase, Climera, and Vivel. The progesterone is Prometrium. There is currently not a testosterone that's been FDA approved. There are also compounded bioidentical hormones. These are typically made in a compounding pharmacy. The issue with compounded hormones is that they are manufactured and sold without FDA oversight for safety, quality, and purity. So what this means is that from batch to batch, you may not be getting exactly what you thought you were getting the previous time. So it may not consistently alleviate your symptoms. And the other thing is compounding pharmacies are getting harder and harder to find. Herbal supplements are also very popular for controlling hot flashes. Typically, we think of phytoestrogens. These are plant-based compounds with structures that are similar to estrogen. They have an estrogen-like effect in our body. They can be isoflavones like soy. They can be lignans like flaxseed. Ginseng is a very popular phytoestrogen. The one thing with ginseng is it does interact with other medications, specifically with a blood thinner called warfarin. So if you were taking warfarin, you would not want to be using ginseng because that would be detrimental. There's chasteberry, valerian. Valerian's been shown to help with insomnia, anxiety, headaches. Red clover also helps with anxiety and depression and can improve vaginal dryness. Black cohosh is probably the thing that's been studied the most. Several studies have shown that women that take black cohosh have significantly fewer and less severe hot flashes than before they started it. There's also some evidence that it helps with anxiety and depression. We also see some improvements with ginger and green tea. Again, if you're going to try one of these things, I would definitely talk to your healthcare provider to make sure that none of them interfere with any medications you might currently be taking. Now, many women are interested in other options. They don't want to do hormones. They don't want to do anything that's like a hormone. Maybe they're not so much into the herbal supplements. And again, there's many options. We can give over-the-counter vaginal lubricants. There are some medications that have been shown to decrease hot flashes. The antidepressant paroxetine does that. There's an anti-seizure medicine called gabapentin that works very well to reduce hot flashes, as well as the blood pressure medicine clonidine. I think another thing that's really important to understand, essential oils can help. They help to relax the body. There's sometimes an aroma effect that is relaxing to the brain. Avoiding triggers, having caffeine late at night or in the afternoon can make it difficult to sleep, may increase night sweats. Spicy foods, especially at dinner, may interact with your ability to sleep or give you hot flashes or night sweats. Certainly, exercising regularly, trying to sleep, and using stress management techniques can also help to alleviate symptoms. And we're going to talk about these things a little bit more. So it's important to understand potential risks that can happen to women in menopause related to brain health, cardiovascular health, bone health, physical health, and mental health, because menopause touches every part of our bodies. So It's important to know that bone density naturally declines with age. We meet our peak bone mass by age 30, and then it's, downhill after that. Estrogen actually has a protective effect on bone. It promotes osteoblastic or bone forming activity. When estrogen declines, we see drops in acceleration in bone loss. That can be called either osteopenia, which is the beginning of thinning bone, and osteoporosis, which is when your bone is very thin. Um, and um, we know that diets low in calcium and vitamin D can weaken bones. The long-term use of certain medications can affect our bones, either corticosteroids or anticonvulsants. Some diseases like rheumatoid arthritis, diabetes, thyroid disease can affect our bones. One of the ways we have of measuring this is something called a DEXA scan, and it actually measures our bone mineral density and gives us what's called a T-score. And based on your T-score, we determine if your bone is healthy, if it's thinning, meaning osteopenia or osteoporosis. There's also something called the FRAX tool that estimates 10-year fracture risk using clinical information and a DEXA scan. As I said, calcium and vitamin D are essential to bone health. Our bodies are unable to manufacture calcium itself. It's an essential nutrient, so you have to get it through your diet or supplement. If your body senses that you are low in calcium, it will actually start taking calcium from your bones and cause more thinning of bones. So for women age 51 and over, we're recommending about 1,200 milligrams of calcium a day, either through diet and or supplements. Vitamin D is crucial for our bodies to be able to absorb calcium from our gut. So typically the recommendation is for women 51 to 70, about 600 international units per day of vitamin D. Over age 70, we actually up that to 800 international units. Again, physical activity, all that is very important for maintaining healthy bones as well. I wish I could say I have the magic menopause diet, but I don't. We do know that nutrition is a key strategy for supporting our health during menopause. Eating well during this phase of life can help mitigate symptoms. It can lower the risk for chronic conditions. It can help manage weight and weight gain and give us a better sense of overall well-being. So, I think the best menopause diet is nutrient dense, something that you're going to stick with. I think the diet that kind of gets the most play for this is the Mediterranean diet. The reasons why this is so good is it's really a nice blend of macronutrients, meaning carbohydrates, proteins, and fats. This diet focuses on fresh fruits and vegetables, nuts, seeds, whole grains. It uses mono unsaturated oils such as olive oil and really promotes omega-3 fatty acids, which are polyunsaturated fats. We can get them from foods like oily fish. It really is important because our bodies can't make omega-3 fatty acid, and it really works throughout our bodies. It's part of the structure of every cell in our body. It gives us energy, and it's really beneficial to our heart, lungs, blood vessels, and immune system. There is also some emerging data on gut health for overall health, and this is why fiber is such an important part of this. Fiber is a prebiotic, and it's a non-digestible fiber, and it helps to feed and stimulate the growth of the beneficial bacteria in our gut. So it enhances our gut microbiome. It improves our gut's ability to absorb calcium, which is so important, and support metabolic and immune health. Foods that are good sources of fiber are apples, artichokes, legumes, lentils, beans, nuts, and whole grains. The other side of this is the probiotic. The probiotic is actually the live beneficial bacteria that help maintain or restore our gut flora. It improves digestion, supports immune function, and may actually reduce symptoms of inflammatory bowel disease, bloating, and even mood disorders. And sources of this are yogurt, kefir, kimchi, kombucha, pickles. When it comes to maintaining a healthy weight, estrogen is normally our ally. It actually supports fat and glucose metabolism. It helps to curb appetite and actually helps our lean muscle mass. So when estrogen drops during the menopause transition, it becomes much easier to put on weight without any changes in diet or activity. And it's really important that we are doing things that help to improve our metabolic rate in order to maintain a healthy weight. Again, eating a low carb, ketogenic, or Mediterranean diet, making sure we're getting enough protein in our diet, making sure that we don't have a sedentary lifestyle. That can all help. Again, after menopause, exercise helps with improving symptoms like sleep disruption, mood, stress, energy levels. It also helps to lower the risk for chronic conditions such as heart disease or osteoporosis. Strength training is a really important component of exercise. It helps to build that lean muscle. It supports our joint and our musculoskeletal system down the road. Cardiovascular exercise is really good. Get our heart pumping. It can be things like running, swimming, biking. That's been shown to decrease the risk of heart disease, clear up some brain fog. In a study, a Harvard study, it showed that 15 minutes a day of brisk walking, I'm sorry, yeah, I'm sorry, 15 minutes a day of running or an hour of brisk walking can reduce the risks for depression. Another study showed that women who exercised regularly had both improved sleep quality and improved mood. Yoga, it's great for helping to lower blood pressure. Um, high impact exercise, I wouldn't recommend doing this unless you've been cleared by your healthcare provider, but it is very good to help, again, with our minimizing the risk for osteopenia and osteoporosis. I personally love walking. I walk a lot. I listen to podcasts, or I try to get a friend to walk with me. Walking with a friend is just a great way to socialize. It helps to build that sense of community. And I think accountability, that if you agree to walk with somebody, someone else is holding you accountable for doing something healthy. And it becomes an enjoyable habit. And we know stress levels are high for women during menopause due to all the things that are happening in our bodies. We know that stress causes increases in cortisol levels, and this can be very difficult. We really want women to find activities that they can commit to, that they like, that they're gonna do. Certainly, meditation is a great activity. It stimulates the parasympathetic nervous system. It lowers cortisol and actually calms the body down. Regular meditation has been shown to decrease blood cortisol levels by 25%. This helps us manage anxiety, depression, mood, and really helps with some of the discomfort that we associate with menopause. Another study showed that there was a I do think that meditation allows us to be kinder to ourselves, more accepting of the view of what's happening in this transition time, and maybe allowing us to be a little less judgmental toward ourselves. And I'm all about self-kindness. So lots that can be done in this space. I want to wrap up by saying menopause is different for everybody. Women should not suffer in silence. We need to be able to talk about this. Not talking about it plays into microaggressions around women being too emotional or angry. 20 to 25% of the US workforce is made up of women who are 45 to 60, so they are actively in this phase. Want to make sure that you have the ability to discuss with your provider, either gynecologist, primary care, midwife, or a menopause specialist, So you're getting what your body needs. If you are not getting answers to the questions you have, you got to find somebody else who can listen and will provide you with those answers. Thank you again, and I'm going to turn things back over to Katie.
Thank you so much, Dr. Robichon. Once again, a lot of the information, kind of the follow ups, things that you just summarized here on this slide. So, thank you for your passion, your expertise. Really appreciate it. So, as mentioned, quickly just want to touch base on some benefits available through Excellus, once again, for our members to be able to access, to learn more, and once again, engage with some of these tools. So, if you are looking for a provider, Excellus has a Find a Doctor tool as well as a cost estimator tool on our website, as well as mobile app that can help you to find providers once again, maybe specific to this topic. So wanted to highlight that tool, as well as our care management team, a team inclusive of a variety of healthcare professionals such as nurses, dietitians, etc., that are all here for our members at no cost. Once again, providing support and resources, maybe helping to, better manage this transition as well. And then this benefit I want to call out does vary by contract. ThriveWell is a digital health and well-being platform for eligible members. There's a lot of great tools and resources specific to menopause, women's health available through this platform with Personify Health. So once again, highly encourage you, if interested, to check out if available and utilize those tools and resources available through there. So with that being said, thank you all for taking the time to join here today. We're going to get to questions in just a second. I know I saw some come through, but just want to give a quick plug for our next webinar in November on diving into diabetes. November is National Diabetes Awareness Month, so we have Amanda Chien, a registered dietitian and certified diabetes educator specialist, going to be presenting on this topic on November 25th at noon. So my colleague Kate, once again in the chat, will put the link to sign up for that webinar if interested, or quickly get out that phone, scan that QR code if that topic is of interest. And last but not least, before we get to questions, my colleague Kate is also going to put in the chat a quick survey. 2 minutes, it should take no more than that, to quickly give feedback on today's webinar and give feedback for future topics. We really want to hear from our members on what topics you want to hear more about. So please take a minute to take that survey as well. So with that being said, want to dive right into questions. Probably going to go over, so appreciate anyone that is able to stay on. Dr. Robish, and I'll read these out loud and allow you a second to answer. We have a couple to get through here. So first one, what if you have a partial hysterectomy at an early age, but still have your cervix, ovaries, etc., but no periods for 12 years at 44 years old? How do you know if the symptoms are actually perimenopause or not? Any suggestions around that?
So that's a great question. And I would say this kind of goes along with the question about an endometrial ablation. So you're not having periods. So that marker is gone. This may be one of the few times that I would look at blood work, specifically looking at some hormone levels to see what's going on, because we don't have the marker of, oh my gosh, it's been a year since I had a period. So sometimes testing hormones can direct us. Again, if you're really symptomatic and we don't know, I would rather start treating in some way or offering some treatments so that you're feeling like your quality of life is not being sacrificed by some of these symptoms. Um, so if you're having a lot of vasomotor symptoms, I would look at the whole gamut of your history and say, okay, if you're 44, you're still young, very young. Um, and that might be someone who, if it's really affecting you, I would talk about estrogen therapy for someone who doesn't have a uterus. If you have a uterus, if you've had an ablation, I would definitely talk about estrogen and progesterone, because we don't want to do anything to stimulate abnormal cells potentially in the lining of the uterus, which could pose other risks. So that's probably one of the few times that I think hormones are beneficial. I mean, I'm sorry, getting blood work is beneficial.
Thank you. Next question that came in. How is peri/menopause affected if there was an endometrial ablation done several years ago causing someone to not have a menstrual cycle? I think that's very similar to what you were just
Yeah.
speaking to, but anything you want to add there?
It's not going to change what's happening from the ovary level. We just lost that signal. We don't have that marker anymore because you're not having periods. So I would really go by symptoms and what's going on in your life, what you're experiencing to make a determination of where we need to go with that.
Recall. Next question. I really like this one. Not to suffer in silence, as you mentioned, but somebody asked, what is the deal with our skin? They didn't have breakouts like this in their teens, and the products for teenagers don't work. Same with fine lines and wrinkles. Any thoughts around that?
Okay, so I hope I gave the message that estrogen in younger women is a fabulous thing. Um, because estrogen controls everything in many ways. You know, I'm being a little bit facetious, but estrogen actually protects our skin. It maintains collagen. It keeps that moisture in our skin. Um, when we go through menopause, estrogen levels drop fairly significantly. Androgen, which is the male hormone or male precursor, doesn't drop as much. So now we have androgen, which is really the thing that's affecting acne, can cause an imbalance between the estrogen and androgen, and that's what comes out as acne on our skin. Um, Androgens are the ones that stimulate those sebaceous glands to make the oil that, you know, makes the sebum, that makes the acne, and that leads to, you know, clogged pores and dead skin. So
Thank
it's a traumatic time for sure.
Thank you for those thoughts. Next question. How do IUDs affect perimenopause and menopause? Any thoughts there?
So another good question. So many women, it depends on what kind of IUD you have. So if you have a hormonal IUD, like typically they're progesterone hormones, so they may stop you from having periods also. It's not, again, not affecting it affects the ovary to some extent in a feedback loop, but it doesn't necessarily change the onset of menopause. And again, that's where I would go also by symptoms, because an IUD is not going to stop hot flashes that much, and the other symptoms that you might get. Um, and, you know, I think IUDs work great in that perimenopause state. It's a great form of contraception, preventing pregnancy. But it does, again, also can mask that using the absence of period for 12 months to signal menopause. Um, you know, in my clinical practice, did allow women to keep their IUD through the perimenopause into menopause, but not long term. Because again, I didn't want to get into any risks of, you know, beyond the FDA approved time to have the IUD. But
Great feedback.
it's a challenge.
Balancing act, if you will, for sure.
Yes.
Couple more questions that have come through. Is it appropriate to get hormone markers, blood work done prior to perimenopause as baseline information?
Oh, that's a loaded question. I think it depends on who you ask. So, um, maybe. I'm not an absolutist, I don't think. Sometimes it is beneficial. Um, but the problem with people who are younger and having regular cycles is it really depends on the day of your cycle that the blood was drawn to know what's happening. If we get it during the week of your period, is it a little more reliable? Maybe. It's just that there's so much change on a daily basis with hormones when you're having regular cycles, premenopausal, that it's hard to really quantify the benefit of those hormones. Um, but I wouldn't rule it out if there were other things going on.
Thank you. All right, last question that has come through and we'll get through here today. Can your OBGYN test for gluteal tendinopathy? I know you mentioned that's a common symptom kind of progressing today, but how to test for that?
So I don't know that your OB/GYN would know how to test for it. I have sent people to physical therapy to confirm the diagnosis because they tend to do a pretty good job. And giving people, you know, hormone replacement therapy, if they're candidates, can help to alleviate that to some extent. But a lot of physical therapy can do it too. It's just that it takes a while and it depends on how long it's been going on, in terms of how much function you're going to get back. But it can be very, very uncomfortable. And, really you need to make sure that it's not osteoarthritis, which is where our x-ray comes in and we can look at the bones and they look good. I'm not sure even an MRI is going to pick up gluteal tendinopathy. I do think like a really good physical therapist who takes care of women and does pelvic therapy can help to identify that, and help to alleviate it.
Thank you. And I apologize. There are lots of questions that came through in the chat. Once again, a hot topic, if you will. So some have received a lot of thumbs up, thinking that it's very similar question for others. So just a couple more, Dr. Robichon, if you wouldn't mind.
Sure.
Big question that came through is what kind of doctor should you seek to talk out about these issues if your OBGYN is maybe not taking you seriously, or you get the sense it is not well versed in menopause treatment? Any thoughts there?
That is a fantastic question. And I think it takes work. Um, and there are some menopause experts in across the throughway, that can help. I think a lot of it is, doing a lot of research on your own. Um, I know that there are podcasters out there that are talking about menopause that can help, but it can be a challenge. And I think it's sometimes doing enough research that you can find someone who does this. I will, somebody put my name in there. That's funny. I will say there are doctors that do it. I have seen Facebook posts about people that recommend doctors who are specific to this. And, I'm not above putting a Facebook post out there to find, names of people that have had success with it. I will say it is not something that is well done in OBGYN residency training. You really have to want to know about this and have a commitment, I think, to women's health, um, you know, to really want to stay up to date and learn more things. I'm going to a webinar in November and I hope to learn more things. So, if I do this again, hopefully I have something else to talk about next year or the year after. But, I think it's just being interested in it and wanting to educate as many people as possible.
Absolutely. And we'll definitely bring you back. Another one. Is it true that if you have been on a hormones for years, you should not stop taking them as they become lifetime commitment?
Okay. So that used to be the case. I started my practice in a different millennium and it was, kind of an all or none. We didn't really individualize therapy. Um, I, again, would go back to that risk factor profile and say, where are you on that? Are you low risk, intermediate risk, high risk? And then in my mind, it would be, how long have you been on it? What dose are you on? Are you on the lowest dose? And, if we're getting to that 10-year, or, I don't know, 5 to 10 year mark, I'd really want to be having conversations about risks and benefits.
Absolutely. All right, we'll get through one or two more. Apologies once again. Thank you, Dr. Robish, on lots of questions that came through. Some you've already kind of covered, so I'll summarize them there. But somebody who's been taking birth control as a young woman most of their life until the age of 40, do you think that factors into the person should only be on hormone therapy for 3 to 5 years, or any thoughts around that?
So, not necessarily. Good question. I think a lot is what other risk factors are there, and a lot of it's going. And how symptomatic are you? Some people, believe it or not, breeze through menopause. We want to hate them, but it happens. They have very mild symptoms. They make it through with nothing, and good for them. Um, I do think that as we're having the conversation for people who've been on hormones and they're approaching that 3 to 5 year mark, I might be starting to talk about some other things, like why don't we play around with the dosing and what can we do instead that still makes you feel like your symptoms are alleviated without increasing your risks for things like breast cancer or cardiovascular disease specifically.
Yep. Another question come through. Have you had patients who had an ablation 10 years ago, so you're not sure if you're really in menopause? This person's 53 and their estrogen blood work said estrogen was really high. Do you think this is of concern?
I don't think it's of concern necessarily. Again, we don't have that marker of periods when you've had an ablation. And I would need to know a few more. If you had blood work, I'd need a few other things. There would be a couple things that I'd need to look at to indicate if that's anything I'm worried about or it's just normal. So one individual piece of information is not enough for me to make a decision. It really is putting the whole picture together. And this is why, you know, we are all so different. And I really do believe an individualized approach to how we get through this, because it is not one size fits all anymore. It is 50 million sizes.
Absolutely. Two more. They'll take the last two. For main symptoms, brain fog, memory issues, irritability. Are mental health medical treatment appropriate if the cause is actually menopause?
Okay, that's a loaded one. um, I think it depends on what mental health things you're thinking about. Like if you have a history of depression and you're having a lot of hot flashes, night sweats, as I said, paroxetine, which is an antidepressant, can help with both. Um, but it's hard to say. And that's sometimes where it's not just either the OBGYN or the PCP. Maybe then we have to get a mental health provider involved to make sure that we are covering all bases and not saying, oh, it's just menopause or oh, it's just depression. Maybe it's all of them. And maybe we need to think about approaching it from all angles to make sure that we're addressing everything that allows you to have the quality of life that you deserve and not have menopause be deterring that or depression or brain fog.
Absolutely. And then last question. Any thoughts on how much strength training a week for those over the age of 50? What would your recommendation be there for that?
Oh, that's a good question because there are two schools of thought. Um, there's one school of thought that's like light weights, lots of reps, and there's another school of thought that's heavy weights, low reps. Um, I honestly would recommend meeting with a personal trainer and having them evaluate where your strengths are and where your weaknesses are and help to set out a training schedule that works. Resistance bands, those are, low, basically lots of repetitions that can help. But it really depends. It depends on your overall physical health. Is there something else going on? Do you have any other medical problems? Are there concerns about, back issues or, knees or hips? So I think that's where getting a full picture is really more important than saying one specific thing or the other. It really is fine tuning it to you.
Yep, absolutely. And 1 minute left, but we'll stop at one. They had somebody ask about having menopause after 21 years. The worst thing for them is painful sex. What are your top suggestions for this that we can end with?
Oh my gosh. Boycotting Viagra? Sorry, that's not nice. No. So there are many things that can be done. Like I said, there's over-the-counter vaginal lubricants that can be used. There's dihydroepiandrosterone that can be a prescription that can be given. Um, there's vaginal forms of estrogen that can be used to help with that. But again, that's something that you really need to see most likely your OBGYN or nurse midwife, because those are the people that are going to address that, make sure that everything looks okay, there's not something to be worried about, and then prescribe that treatment.
Thank you. Well, we are right at the top of the hour once again. Thank you all so much for staying on. Dr. Roberson, thank you for the additional Q&A
Thank
time here.
you.
We appreciate the time today. We'll hopefully see everyone back next month, but thank you again and have a wonderful day. Bye,
Thanks.
everyone.